This is part 3 of chapter 14, a continued discussion of psychological disorders. In this show, we're going to go over some particularly severe psychological disorders. The first one is bipolar disorders. There's a variety of disorders in this family. Lately on television, there have been advertisements for a medication for a certain variety, type 2 bipolar disorder. The different disorders are separated by some differences in symptoms and severity of symptoms and the particular symptoms, but they all follow the same. They'll have many things in similarity. Formerly, this was known as manic depressive disorder, and had been included as a depressive disorder in the older DSMs. It is been pulled out as a new category in DSM-5, and you've heard that quite a bit in this chapter. That was one of the great advancements of the DSM-5, is kind of this greater discrimination of disorders. The separation of bipolar disorders from depressive mood disorders in prior DSMs came about because in bipolar disorders there is the occurrence of psychotic symptoms that make them unlike the other mood disorders. For example, depression is primarily a disorder of mood, of outlook, of how one perceives the world, and it tends to be negative. It tends to be filled with sadness and a lack of energy. Bipolar disorders sometimes have symptoms that are more like psychoses, people seeing things that aren't there, hearing things that aren't there. There also is a greater family history or shared vulnerability with the bipolar disorders than there are with the mood disorders. Even though there is some degree of relatedness with depressive disorders, it is enhanced with the bipolar disorders. We called major depressive disorder unipolar disorder because it was a mood disorder that only involved a depressed mood. But bipolar disorder, you see the bipolar, two poles, the mood shifts between two directions, from depression to what's called the manic state. Whereas depression is extreme sadness and lethargy, a manic state is the other end of the spectrum, and it is extreme, not joy, but extreme energy and extreme kind of not consciousness, but extreme agitation. In the manic state, someone often becomes hyperactive, talkative. They will talk rapidly, often not even making sense. They'll show a decreased need for sleep. They often will engage in activities that they don't normally engage in, and often these activities are self-destructive or dangerous, such as spending sprees. There's kind of no check on their behavior. It's like the little part of the brain that tells them not to do things is shut down, and they kind of become completely impulsive and bounce from activity to activity. Risk-taking is also common in the manic state. In the manic state, probably the best conceptualization I can give you of the manic state is the former comedian Robin Williams, who did commit suicide. In many of his performances, he would seem to be out of control, talking rapidly, and just bounce from idea to idea, and that pretty much embodies a manic state. To be classified as a manic state, it must last a week, but it may last for months. So this is, again, kind of part of what the DSM does, is try to draw a line between normal, regular behavior and disordered behavior. Someone might be in this manic state, a state of extreme elation and joy and energy for a day. That's not abnormal. That's not atypical. But where it becomes atypical and abnormal and a problem for the individual is when this state persists. Because when someone is in a manic state, their functioning is often severely impaired. They may not go to work. They may not attend classes. They see other things as being more important and exciting and necessary, and they tend to ignore the day-to-day necessities of living, much like individuals in a deep unipolar depression might. Um, Even though the manic state does not involve sadness, does not mean that it is a positive thing for this individual in their life. One of the difficulties with treating bipolar disorder, and it is treatable with medications and therapy, is that individuals often will go off their medication and off treatment when they're in the manic phase because they perceive it as this heightened state of awareness and consciousness, and they're getting a lot done and they feel very creative. But the problem is that's only their perceptions. It's not the reality, and their functioning is often severely impaired. Bipolar disorder was pulled out of the mood disorders category because it seems to share also some characteristics with schizophrenia. Schizophrenia is a severe disorder of impairment and the perception of reality. The word schizophrenia means split mind, but really what schizophrenia involves is a split from reality. An individual who is in the throes of schizophrenia and a full-blown schizophrenic episode displays a break with reality and their place in the world. And there are some symptoms of the manic disorder that are very similar to what individuals with schizophrenia display. The general symptoms of schizophrenia involve at least 2 or more of these following symptoms, and they have to last for about 6 months. These are called, the symptoms we're going to go through here are called positive symptoms because they are symptoms that are not typically present, or really what they are is they're present in more abundance than they would be in a non-schizophrenic individual. So they're kind of increased symptoms. For example, delusions. Delusions are false beliefs. If someone believes that they are the Queen of England, but they are indeed not the Queen of England, that is a false belief. Schizophrenics tend, this is part of the break with reality, they tend to have these ideas and beliefs that do not fit the state of the world. For them, they're perfectly real and they make sense, but to everyone else, they might seem off-putting, scary, makes people feel uncomfortable because someone may believe that they are an alien from a planet outside the solar system, and that they're here on Earth to prepare humanity for the coming of the alien race. There's no reasoning with these individuals about their false beliefs. They are fully set in understanding them and living with them. Hallucinations are also common with individuals with schizophrenia, and a hallucination is a false perceptual experience. Individuals with schizophrenia, a common hallucination is hearing voices, and the voices will tell them to do things or not do things. Now this is where it kind of gets interesting. We all hear voices in our heads. We all have an inner voice. When you read, you probably read in an inner voice. But to the individuals with schizophrenia, these inner voices aren't perceived as themselves. They're perceived as coming from without, some exterior source. It might be demonic, it might be aliens, it might be the government trying to get a hold of them. They're tied in with the delusions, but they are perceptual experiences as real to them as seeing and hearing other people are. Some hallucinations are visual. There may also be tactile hallucinations as well, where people might feel things. Individuals with schizophrenia also display highly disorganized speech. Their speech will be rapid and fast and incoherent. It will follow the laws of syntax. It sounds like normal language, but the ideas and concepts don't fit together and bounce around quite a bit. This video clip will display some of these symptoms, again, with individuals who are suffering or living with the disorder. And again, this is also posted on Blackboard on materials for Section 4.
It's characterized by symptoms primarily of auditory hallucinations, hearing voices. Voices often comment upon the person's behavior, or they may tell the person to do things. Second most common, patients will have visual hallucinations, and less commonly will have tactile and rarely olfactory or gustatory hallucinations. They also have what are called some of the first-rank symptoms of Schneider, including ideas of control, a sense that one's actions, thoughts, or emotions are being controlled by an external influence.
The demons in me control my eyes. Every part of me is demonic, where I can be beheaded and my head will rejoin or pop up a new one. And that is what happened to me when I got grounded by my orbiter in a place called Jedi Gardens.
Nowadays, a radio chip or X-rays. In the old days, voodoo was a common cause for that. Symptoms of thought insertion and thought withdrawal, where strange thoughts either appear in the person's mind or thoughts are taken out of your mind.
I can be thinking something and then the thought will be taken away. And then I have to just think and think and think and think until the thought come back again.
Mm-hmm. And finally, delusions, fixed false beliefs not understandable within the context of the person's background. Common delusions include paranoid delusions, the belief that the CIA or the FBI is following you, has tapped your phone, or that some group is conspiring to poison you or to interfere with your life in some malignant way.
Well, again, the big one was about the CIA, that the CIA was training me to spy, but I also believe that they were grooming me to be in a James Bond movie.
And the voice would tell you this?
Yeah.
All this occurs in the setting of clear consciousness, no disorientation, and no obvious signs of delirium.
The delusions often are classified in certain categories. They may be delusions of grandeur, in which an individual believes that they are more important or famous. I think that last individual, that would be a delusion of grandeur. He believes that the CIA is training him to be a spy and also to be in the next James Bond movie. Sometimes delusions are of persecution, paranoid delusions. They would believe that someone is out to get them, or that there's demons controlling them. And that first individual would qualify, I think, as having some delusions of persecution or paranoia. The first individual also, I think, kind of clearly demonstrates that disorganized, rapid, incoherent speech patterns. He says, demons control every part of me, and this happens. My head was cut off and it reappeared. And this happened to me when my auditor was chasing me at a place called the Jedi Bar. Just this rapid, incoherent set of ideas. But like the doctor says there at the end, these symptoms happen in the context of clear consciousness. They're not bouncing around the room, they're not screaming, they're not yelling. These delusions, hallucinations are presented in a very matter-of-fact way. Other symptoms of schizophrenia, you can imagine there's a deterioration of adaptive behavior. There's often inappropriate behavior. behavior that is out of the norms of society or laws. Individuals may engage in sexual behaviors with themselves or others in public. Um, they may treat a sidewalk as a landing ramp, a runway, if they have some delusions that they're a pilot or that they can fly. Um, they will not have any inhibition to these inappropriate behaviors. And there's also motor disturbances that are associated with the disorder. The woman in the last clip had a kind of a head tick, a head bounce, and the last fellow had some unique kind of facial movements and blinking kinds of behaviors. Those are typical of schizophrenia. Um, in that sometimes there's these odd mannerisms that individuals will develop. Other times, the motor disturbance is a muscular rigidity that's called catatonic behavior. Individuals will freeze in a pose for a long amount of time, literally like they are a statue. In prior versions of the DSM, there was different subtypes of the disorder. There'd be paranoid schizophrenia or such. One was a catatonic schizophrenia, and individuals who primarily displayed these rigidity of motor behaviors, these freezings and posings, were called catatonic schizophrenics. Now they're classified in terms of the symptoms rather than subtypes. In terms of the positive symptoms that we're discussing, as we'll get to some negative symptoms. And the strange or odd mannerisms were displayed, as I said, in the earlier clip, but there's one coming up that demonstrates these mannerisms in a very striking fashion. The negative symptoms of schizophrenia include withdrawal. An individual with schizophrenia doesn't feel like they need a lot of social contact with other individuals, so they don't go to work. They may not talk to family. They might talk to themselves or the voices in their heads, but they generally don't interact with other individuals when they're in the severe parts of the disorder. And they display an absence of the normal behavior, motivation, and emotion. They may react intensely, but in the wrong way. Becoming intensely sad after they hear about some good news in their family, or happy when something sad happens. Or they may display no kind of appropriate emotion at all. Just kind of whether they're talking about something good or bad, it's kind of the same flat, monotone response to the world. These are the negative symptoms. Negative means that these are ones that, behaviors that tend to decrease in an individual with schizophrenia compared to an individual without the disorder. This clip, again, is also on Blackboard, and we're going to watch it. It displays one individual. He is hospitalized. He's institutionalized with the disorder, and it's at a teaching hospital, and there's a class of medical health practitioners who are learning about the disorder and how to work with individuals with schizophrenia. And he is part of their rounds in a sense, but in this case, he comes to them. You will see delusions, you will see hallucinations, you will see the mannerisms, and the rapid incoherent speech. And then at the end of the clip is some other parts of the institution. And, when individuals are in these a full-blown schizophrenic episode, they often have difficulties living out among themselves, among other people. Often they're taken advantage of, or they're seen, they may even be threatening or dangerous to be around. But often, mostly, they're more a danger to themselves because they don't take care of themselves. They don't display proper knowledge of the world, don't recognize highways and trains as dangerous. So they end up being institutionalized. So that shows a ward in a hospital, and generally these things do not exist anymore. in the 70s and the early 1980s, they were much more common. And individuals, this is where they would live day to day. They wouldn't be here for a short time. They would be in those places for a good part of their lives. And in the 1980s, there were some breakthroughs in medications, and views changed to see these institutions as keeping people in these institutions as being cruel and inhuman, and that with medications and proper management and therapy, that these individuals could live outside institutions, in such halfway houses and things like that. It also became state governments became aware that it was theoretically cheaper to put these individuals out in the world and pay for their rent or at a halfway house than to maintain these institutions. So there was some societal and governmental push to close these institutions and get these folks out. What ended up happening though, is that these people generally were so severely in the throes of the disorder that they could not care for themselves. That means not taking medication, not being able to hold a job. So the state would pay for them to live in places that didn't cost very much, so often in cities, in the Rust Belt, maybe cities that were seeing an exodus of individuals. So these would become kind of dumping grounds for these poor folks. There were theoretically places set up where they could get their medications, but they weren't functional enough even to get themselves there to get the medications. So a lot of them fell through the cracks, and I don't think it's any coincidence that in the middle 1980s, late 1980s, there was a great rise in homelessness in American cities. And for the most part, it was these individuals who had been thrown out of these institutions. Now, there's still an ongoing debate as to whether it was more humane or less humane to keep them in institutions versus letting them out. Unfortunately, I think it was done on a wholesale basis rather than individual. So I'm sure some people did better outside of the institution than within. But clearly there were people who suffered when they were no longer in the care, the close care of an institution.
Gerald S. is grossly delusional and thought disordered. He is currently on the following medications: haloperidol, 32 milligrams daily; benztropine B, 4 milligrams daily;
How are you doing? Not doing so hot. I think and feel as though people have called me here to electrocute me, judge me, put me in jail, or kill me, electrocute me because of some of the sins I've been in.
Is this a new feeling for you?
The main thing is don't get excited, but the thing is it's not a new feeling, no. I'm scared of people.
Must be very frightening for you, though. Feel like you're about to get killed.
I'm so scared I can tell you that picture's got a headache.
Can you tell me more about that? The picture has a headache? Could you?
You want to know?
Yes, I do.
Okay, when a sperm and an egg go together to make a baby, only one sperm goes up in the egg. And when they touch, there's 2 contact points that touch before any other 2. And then it's carried up into the egg. And when they fuse, it's like nuclear fusion, except it's human fusion. There's a mass loss of the proton. One heat abstraction goes up in the electron, spins around, comes back down into the proton to form the mind, and the mind can be reduced to 1 atom.
Jerry, in one patient at one time, shows almost every one of the major features of schizophrenia. His thinking is disorganized. The thoughts are loosely connected. He has formed delusional ideas. Some of those delusions are grandiose. Some of them are paranoid. He has disturbances in his mood. His mood is, in some cases, almost absent, and in other cases is totally inappropriate. And his behavior is disordered. It's unusual. He has mannerisms that are inexplicable. He has purposeless, aimless behavior around the ward. He's a textbook case. He combines all those things in one person.
At this point, what would you like us to do for you?
I would like you to get me off of cigarettes, get me dried out, cleaned up, so I can go home and get a job in a bakery and go to medical school.
I guess the way I think of schizophrenia is that schizophrenia is an illness. It's a total picture. It's not like a peculiarity of behavior. It's not as if somebody has a sort of idiosyncrasy or has some peculiar way of doing things or thinking things. Schizophrenia is an involvement of a person in illness. There is abnormalities of behavior. There are abnormalities of thinking. There are abnormalities of feeling. There are abnormalities of the way people move across a room. There are peculiarities in what people perceive. There seems to be a very global impairment of what we think of as the highest psychological functions, the most intricate, sophisticated, complex psychological functions that people have.
What happens is you've got a healthy, or can have a relatively healthy young adult, or a young person turning into adulthood, who begins to go into a psychosis, withdraws from the people who he or she loves, and is distant from those people. At the same time, that individual, that child, is clearly in enormous emotional pain, psychological pain, can't interact with people, and has a disease which can last for years.
This is the institution where Jerry lives.
I don't know if you just cried hard up after school. You should have been going. Try to get a ball floor.
In order to understand the kinds of patients that we have on this ward, you've got to remember that schizophrenia breaks down into the rule of quarters. A quarter of people who get the disease will get well and not get sick again. Another quarter will get relatively well on medication and be able to live independently. A third quarter will be able to live in a group facility on medication, and the other quarter will do very poorly. 10% of the people, in fact, will suicide within 10 years, and 15% won't respond to medication at all. Are you going to be going home this weekend? You are. People with chronic schizophrenia, when they've had the disease for more than a few years, almost certainly have some brain damage from the disease. The same kind of chemical and physical processes that cause the disease also cause damage to the brain. It's sad because you have people who look normal for the first 15, 17, or 20 years of their lives, and then you have this devastating illness, so that there is kind of a disconnect between the way they start their lives and the way many of them spend the rest of their lives.
We've talked about the biopsychosocial model earlier and the diathesis stress model. And there's several views on how schizophrenia comes about in an individual. One possible understanding is the dopamine hypothesis, because it's been noted that individuals with schizophrenia have an excess of dopamine activity in their brain. And we talked about this earlier when we talked about neurotransmitters, that schizophrenia involves excess dopamine, and remember it was Parkinson's that was associated with a decrease of dopamine activity. So there's some belief that something happens in one's brain, be it biological or induced by some situation, some environmental event, that causes the brain to produce too much dopamine. But the problem with the dopamine hypothesis is that medications can control dopamine very well, and dopamine blockers do not always lead to favorable changes. Simply changing the amount of dopamine does not necessarily help the individual. And when they do work, the drug levels change, the dopamine levels change immediately. We can measure the reduced dopamine, but the recovery is delayed. The symptoms still persist. So it's not exactly clear what the role dopamine plays is, but it is clear that it's more complex than just an excess of dopamine activity. While there is this demonstrable increase of dopamine activity, making that go away does not make the disorder go away. So there must be other things involved, other neurotransmitters are involved, and there's some interaction with those things. Or as the individual in the last doctor said, often individuals with this disorder, their brain physically changes. There's brain damage as a result of the disorder over a period of time, and no medication is going to change the brain back physically the way it was. They also talked about the development of schizophrenia, and often individuals will first develop the disorder in adolescence, middle or late adolescence. And it has been demonstrated also to have a biological or genetic kind of relationship. This chart shows the risk of developing schizophrenia as a function of relationship. And you see at the top it goes over here, first degree relatives, second degree relatives, third degree relatives. So as one rises on the y-axis, there is a greater degree of genetic similarity. And then the x-axis is the risk in percent. So if you look down here at the general population, schizophrenia, for as well known as it is actually fairly rare, and it's 1 to 2% of the general population. So anyone in the population, in the country, in the world, has about a 1% chance of developing this disorder. But that chance rises when there's a family member with the disorder. For example, first cousins raises the level to about 3%. Being a spouse of a patient, curiously, also raises it to about the same amount. So it seems, in this just two things here, that there's some biological as well as environmental things that may explain it. For example, first cousins is a genetic link. Spouses is not a genetic link. But that doesn't mean that schizophrenia is catching, because remember, people don't choose their spouses randomly. They choose individuals to partner with who display characteristics that they find appealing, that they like. So it could be that individuals with schizophrenia are drawn to other individuals with schizophrenia. And that could be a biological thing rather than environmental. The second degree relatives, you get to half siblings, grandchildren, nieces, and uncles, and you see the green bars, there's a little higher risk of developing schizophrenia. The blue bars are what we call first degree relatives. So here's siblings, right? If in a family one sibling develops the disorder, that means there's about an 8%, we'll call that about 8, there's about an 8% chance another brother or sister of that individual will develop the disorder, right? Compared to 1-2% in the general population, if a sibling has it, it's about 8%. If it's a dizygotic twin, now this is interesting, right? Fraternal twins, dizygotic, have the same genetic relationship as regular siblings, but there's an increased risk for the dizygotic twin. So if one twin were to get the disorder, there would be about a 17% chance that the other twin would get the disorder. Increased over the genetic similarity of regular siblings, which is the same, which suggests that, again, there's some kind of environmental thing going on there as well. The highest likelihood, notice this huge jump up to these two bars, is if two parents have the disorder, there's a greatly enhanced risk of disorder. So an individual whose parents both have the disorder has about a 40 6% chance of developing the disorder. MZ twins is the highest, is monozygotic. These are identical twins. They share a tremendous amount, almost 100% of their genetic material. And that's about a 48% chance. If one twin gets the disorder, 48% chance the other twin will get the disorder. So there is a familiar pattern. There is some genetic or biological factor in the disorder, and the closer one is related to the individual, that there is an increased risk. But I will point out one thing. Notice that the risk is always less than 50%, even when it's highest. It's less than 50% of developing the disorder. So it seems that there's environmental factors as well. Right? Think about this. Monozygotic twins, if one twin has it, doesn't automatically mean the other one will get it, even though they share the genes. It says that the twin who did develop the disorder underwent some experience that exploited that genetic makeup, and the other twin did not get that. So there does seem to be this diathesis stress that the family relationships, the genetics is perhaps a weakness, and that some environmental factor, some stress can exploit. The final set of disorders we'll talk about are dissociative disorders. And I want to mention them very briefly because there's a lot of misunderstanding about dissociative disorders. First of all, they're very, very rare. They're commonly portrayed on television, which make them think that they're more common than they are, but they are very, very rare. And I do want to also talk about it because this one disorder, dissociative identity disorder, is often confused for schizophrenia. Dissociative identity disorder used to be known as multiple personality disorder. And to be truthful, this is probably closer to the idea of split mind than schizophrenia is. With dissociative identity disorder, an individual changes between two or more different personalities. Their mannerisms change, their likings change, their patterns of speech may change, their preferences for clothing or food may change, and they're often not aware of these differences within themselves. This happens. This is a common thing on television and movies to portray this disorder, but it is very, very, very rare. What makes it different from schizophrenia is the lack of delusions, the lack of hallucinations. Even though these individuals are having difficulty in the world, it doesn't seem to have those psychotic symptoms. This was recognized by the DSM, and there's a typo, that should be DSM-5, but it's a curious disorder. Not all clinicians believe in it, because this is a disorder that can be faked. It is almost impossible to persist and make a clinician believe that one is schizophrenic when they're not. But multiple personality disorder is one that could be faked. And if you think about it, this is what actors and actresses do all the time, is take on a different personality and portray someone very different from themselves. So if someone were malingering, if they were looking to get out of some personal responsibility or avoid a crime, this is something that could be faked. But there are some things that have been noted, such as changes to the eyes, how the eyes behave, that cannot be faked. So the sense is that it is a real disorder, but many of the cases are really not such, that they're probably malingering. The causes of this disorder are unclear, but generally these dissociative disorders seem to come about as a coping mechanism for an individual to get away from sexual or physical abuse or negative things in their life. The word dissociative means to break. to separate. And by developing different personalities, an individual can compartmentalize or separate their current self with some deep, deep unpleasantness that their prior self experienced. Two other dissociative disorders don't have multiple personalities, but they have the separation, a cognitive separation of the individual from the conscious awareness or memories of their previous thoughts. So the break here isn't in personality, but the break is really from the facts and circumstances of one's life. And again, it's believed to be an extreme response in terms of avoiding unpleasantness and sadness and cruelty in one's life. A dissociative amnesia is an inability to remember important personal information. So someone may kind of selectively forget elementary school if there were some sexual abuse or child physical abuse that occurred. A dissociative fugue state is this complete inability to remember one's entire life. And every so often you hear on the news, there was a case, I think in Shelton or Derby, 5 or 6 years ago, where an individual kind of came into the police station and asked for help, and he didn't know where he was and didn't know where he lived or what his name was. And they couldn't sort it out. He had no identification on him. So they put his picture on television, and it was, if you know this individual, please contact us. You see that every so often. You rarely get the follow-up. I think typically it is this dissociative fugue state where someone just kind of walks away from their life and even does so psychologically by avoiding all memory of their life. Now, these amnesias, you can get amnesias like this from traumatic events like brain surgery or car accidents. And these are individuals who have these memory kind of issues that are purely psychological in origin. There's no physical trauma that would lead to it. All right, this is the end of the slides. Have a good day.